Hello and welcome to clinicalpath.com. Today's lecture is on atelectasis and acute respiratory distress syndrome. Atelectasis refers to a condition in which there is loss of lung tissue due to decreased volume within the lung. And there are three basic ways that one can lose that lung volume. One can do resorption, which is also due to obstruction. There can be compression of the lung from the outside in, or there can be contraction of the lung due to scarring. So let's start with resorptive atelectasis. Resorptive atelectasis, which is also called obstructive because it's due to obstruction of the airway, occurs because airway collapses due to various pathology causes. Well, air spaces stay open due to three basic mechanisms. Three basic mechanisms that keep an airway open are production of surfactant. And it's important to remember that surfactant is stimulated by deep breathing. One must continuously breathe. And then the last thing is one must clear airways by coughing. So any condition that lacks deep breathing, continuous breathing, and the ability to cough is going to lead to an inability to keep airways open. So there's two different ways that one can find airway obstruction: small airway obstruction and large airway obstruction. Small airway obstruction is classically seen postoperatively. After surgery to either the chest or the abdomen, it can be very painful to breathe. And so that leads to shallow breathing. And remember, surfactant production is associated with deep breathing. As well, there can be an inability to cough because, of course, that is painful as well. Continuous breathing should not be a problem, although there are often small pauses during the anesthesia phase during periods of intubation and the like. So postoperative has a number of risk factors for airway to collapse, particularly the small airways. The commonest presentation is a day 1 postoperative fever. There's never really been a good explanation for where the fever comes from, but that is the classic discussion. And remember, the classic time for peak neutrophils is day 3. So one doesn't think of day 1 as soon enough to have a bacterial infection either in the organs or in the wound. So this day 1 is too soon for infection. If one needs to work up the diagnosis, one can do a chest x-ray, and on the chest x-ray one will see, because it's a small airway, this line which represents the collapsed lung tissue giving an increased density. The treatment is proper respiratory toilette, and that allows then for coughing, supervised breathing, and most importantly, positive end expiratory pressure, which will clear all of the small mucus plugs in the small airways and allow for proper surfactant production. The second kind of resorptive atelectasis is that of the large airways. And here age makes a big difference. In adults, the commonest cause of large airway obstruction is going to be a malignant mass, classically a carcinoma. However, in children, it's much more likely to be a foreign body. And the commonest foreign body, no kidding, is a peanut. And there's a reason for that. When you take a look at what a peanut is, a peanut has this very smooth torpedo-form shape and a slippery surface. And children really don't have fully coordinated swallowing reflexes, and so it's easy for them to get that back by the epiglottis and aspirate it instead of swallow it. And if you take a look at a jar of Planters peanuts, you'll see there actually is a legal notice warning that children should not eat peanuts unsupervised. Well, if it's a large enough airway, it's now going to have a different presentation than fever. The classic presentation is going to be shortness of breath, because there is a mild degree of hypoxia because we've lost ventilatory lung surface. So on physical exam, one probably won't find any evidence of a lung noise, but one should be able to see an increased respiratory rate. and if one does a pulse oximeter, one will see a decrease in the saturation pressure. Definitive diagnosis will be by imaging, and chest x-ray is pretty good for that, and one can then recognize the normal lung anatomy by the area of loss. So for example, as we see in picture number 1, that would be the right middle lobe. And just as one would expect from any basic lung anatomy, this would be, for example, the left upper lobe. So x-ray is a pretty good example of that. And then obviously the treatment is you have to open the airway up so that one can ventilate the abnormal area of lung. Compressive refers to extrinsic or external compression of the lung, and the commonest way one gets that is accumulation of fluid. And your basic fluids are going to be air and liquids. And your most important liquids are going to be blood and an effusion. So let's take a look at each of those in turn. When one talks about how one gets air in, one's really talking about a pneumothorax. But not just a spontaneous pneumothorax, because collapsed lung really doesn't cause compression. It really has to be a tension pneumothorax. And a tension pneumothorax is seen in trauma when the tear gives a flap valve function. So if one takes a look at the chest wall here, and there is an injury of the pleura that leaves a flap, when one breathes in, the flap will open and leave the air. However, when one tries to expire, we close the flap, and that then expands the chest. And these are obviously recognizable on imaging because one can see that the lung is compressed. All this is going to be airspace, and this is the residual lung, and it's going to shift the mediastinal structures, and the trachea will deviate away from the side of pressure. And this is a true battlefield emergency because putting any kind of structure that will decompress the lung will allow the patient to stay alive on their one remaining lung. The other that's very important is effusions. And the idea behind effusions is to recognize whether they are transidates or exudates. That's about a fundamental idea as you could have in medicine. So remember that when we have a surface, we're talking about the Starling forces. So here's my structure here, and the Starling forces state I have hydrostatic pressure driving the fluid out, and I have oncotic pressure mostly from albumin drawing it in. So any situation with increased pressure or decreased protein will allow a filtrate, because this is an intact membrane here, which means that cells and high molecular weight structures cannot leave. So a transudate is against an intact epithelium, and in the lung, protein doesn't play a part of this, so in the lung, it's due to increased pressure. So transudates of a lung effusion are related to congestive heart failure. And that's very different than an exudate, because an exudate says there's actual physical damage to my pleural surface. So what that means is not only does fluid come out, but also protein can come out and also cells can come out. And so when one finds that, then one knows that one has an exudate, that there has been some destructive process to the pleural surface. The only two significant causes of that destructive surface are going to be inflammation and neoplasia. So when one finds an exudate, then one has to have typically recently had a pneumonia as the commonest cause of inflammation of a pleura, or one has malignancy seeding the pleural surface. And therefore, when one takes a look at how one's going to see this clinically, we're going to see here, for example, a right-sided pleural effusion. The patient's going to present with shortness of breath. On physical exam, one's going to have dullness to percussion and absent breath sounds. And then when one taps the fluid to get it out, one is going to find an exudate. And then either the presence of neutrophils for inflammation or malignant cells for spread along the pleural surface will give one the diagnosis. Compressive atelectasis is the least common because this is due to scarring. There really aren't a lot of causes of scarring that happen in clinical medicine. The commonest one is probably irradiation for neoplasms. One can sometimes have chemicals introduced when you try to obliterate the space of the pleural space for recurrent ruptured bullae or to get rid of a malignant effusion, but obliterative talc, for example, can cause fibrosis, and then the lung simply scars down. So atelectasis can be resorptive, which is obstruction, small airway post-op, large airway, tumors in foreign bodies. Compressive is due to fluid, and the two important diseases are going to be a tension pneumothorax and a malignant effusion. And then contraction is due to scarring, typically to something like radiation. Acute respiratory distress syndrome is a clinical syndrome in which there is an acute onset of dyspnea that is associated with a decreased response to administered oxygen, decreased compliance in the lung, and on imaging there are diffuse infiltrates. And for many years there's never been a standard consensus for what this was. And there always used to be two entities that were called acute respiratory distress syndrome and then acute lung injury. But in 2011, there was a conference in Berlin that established the Berlin consensus criteria. And in that, they fused and joined acute lung injury into ARDS. So now there's only acute respiratory distress syndrome. And they defined each of the elements of this so that it could be reproducible. Acute was defined that it has to all occur in less than 7 days. And in point of fact, almost always it's less than 72 hours. And that gives you a good sense of what acute means. When we talk about the lack of response to oxygen, this is measured by what is called the PF ratio. And the PF ratio stands for the ratio of the blood gas oxygen over the inspired oxygen that one gets. So normally at room temperature sea level, the normal PaO2 is greater than 95 millimeters of mercury, and the inspired air is 21% or 0.21 oxygen. So in a normal person, one can see this should be greater than 400. If, however, there is a perfusion defect, such as our hyaline membranes, then when we have an acute respiratory distress syndrome with its lack of response to oxygen due to these hyaline membranes, this ratio is going to be less than 300. So that then becomes our criteria for not responding to treated oxygen. And then the last part of the definition is that there have to be abnormal imaging. And that could be CT or chest x-ray, but when one takes a look at that, one can see that in this there are these areas of consolidation, and these represent the exudative fluid filling the alveolar spaces. It's important that you have to rule out other causes that can mimic this picture. And the two entities that you have to rule out is you have to rule out congestive heart failure because it has many of these same findings. And a standard way of doing that is to show that the BNP is normal. The other thing that you have to rule out is atelectasis. And atelectasis is confirmed by showing that you can use normal pressure to insufflate the lung. So if you ventilated your pressure, you can show that there's no increase for our continuous positive airway pressure. That would be seen in atelectasis. It's going to be high in acute respiratory distress syndrome. So why does the patient look like this? The answer is because this is an acute, diffuse, inflammatory injury to lung that leads to a permeability defect in the alveolus. and that permeability defect with its exudate then gives you hypoxia with VQ mismatching and decreased lung compliance. And that's what lets us see in the chest X-ray these opacities, because it is this fluid, this exudate, that's filling up the alveolar space. The hallmark, the pathology of this is diffuse alveolar damage, which is proved histologically by the presence of hyaline membranes. And that's what we see right here in the image. That area, this lining layer of red here that we see lining the alveolar space, that is the hyaline membrane that proves diffuse alveolar damage. So let's walk through and see how that happens. Well, the etiology is there has to be damage either to the endothelial cell or to the epithelial cell of the alveolar wall. And the commonest causes that damage the endothelial wall are going to be sepsis. There's lots of other causes that one can see here. One can have pneumonia. That would be another cause. Pancreatitis can do it. Any situation that gives systemic inflammation can do it as well. The epithelial cell can be damaged by other entities such as gastric aspiration, and the acid damages the epithelial cell. Other causes are patients that are in burning buildings and breathe in the toxic smoke. So anything that damages either the endothelial cell or the epithelial cell is going to then allow for an exudate. Remember that the definition of an exudate is that it not only has fluid, but it also has high molecular weight proteins and cells. And so that damage then allows for the attraction of the neutrophils, and now the neutrophils bring in all of their damaging enzymes, and that then leads to even more of the damaging exudate. So it becomes a positive feedback, injury to neutrophils, neutrophils then to further damage, and then the presence of the exudate, and that leads to the VQ mismatching and the loss of elasticity of the lung. Well, what causes that diffuse membrane? Well, remember, the type 1 pneumocyte is very effective at pumping water, but it cannot pump out the high molecular weight proteins. The high molecular weight proteins require phagocytosis by monocytes, and they're not going to appear for 7 to 10 days. So if the patient dies before that, you can actually see that high molecular weight protein lining the alveolar space waiting to be cleared. The other thing that's important to think about is, remember, if I've got oxygen here in the center of my alveolus, it now has to diffuse through not only that hyaline membrane, but also that inflamed edematous alveolar wall. So when one thinks about why do I see this abnormal ratio, one can see then where the diffusion barrier has to be that defines the clinical hallmark of this underlying pathology. So acute respiratory distress syndrome is characterized by diffuse alveolar damage and hyaline membranes. So then what happens to our patient? The natural history of the acute respiratory distress syndrome really breaks into weeks. First, we start with our initial insult. And remember, that can be endothelial cell, such as sepsis or pneumonia, or it can be epithelial cell, such as breathing in burns or having a gastric aspiration, and that then creates our acute process, and that edema is an exudate. So this then starts our exudative phase. The type 1 pneumocyte pumps out the water, but we're left with our high molecular weight proteins, and they form our hyaline membranes. So at this point then, our patient is going to have an increasing acute onset of shortness of breath, less than 7 days. They're going to have a PaO2 over FiO2 of less than 300, and they're going to have a high pressure required to inflate their lungs as proof of loss of compliance. And then, as is usual, the macrophages appear around day 7 to 10, and then they are going to either clear the process and the patient will return to normal, or through mechanisms not understood and unpredictable, they will then pursue onto fibrosis and permanent lung damage. So how do you predict what happens to your patient? Well, young people do better than old people. But otherwise, it basically depends upon correction of whatever the underlying problem is. So if they have pneumonia, clearing the pneumonia. If they have sepsis or other systemic inflammatory response pattern, it is correcting whatever the cause of that is. So correcting the primary disease really is the outcome of this entity. And after that, one really is left with the supportive care of adding oxygen and ventilatory support. And that brings us to the end of this tape. Thanks for listening.